nurses. Welcome into your EKG interpretation review. Now, I know a lot of you didn't get a thorough review of EKGs in school. That's okay. We're going to break it down, make it nice and simple so that you know the basics you need to for the NCLEX. And that means we need to start off with simply what an EKG actually means. I promise this is going to make everything so much easier when you go to interpret your findings. So 3 big components that you need to be aware of: the P wave, the QRS complex, and the T wave. Now, the P wave is that very first little wave. It represents atrial depolarization, when the top part of the heart, the atria, squeezes and contracts. The QRS complex shows us the same thing, but for ventricular depolarization. So that's why it's much bigger than the P wave. The ventricles are really big, really strong. They take more energy to depolarize and contract. Lastly, we see a T wave. T wave represents ventricular repolarization. Repolarization is when the ventricles get ready to contract again. They reset. Now, you're probably asking right now, well, Morgan, what happens when the atria repolarize? Or do they repolarize? We don't see a wave for that. Well, we do know that the atria repolarize, but we can't see it on our EKG. That's just because the big QRS complex from the ventricles actually covers it up. So here's what you need to remember. P wave atria, QRS complex ventricles. That's really going to be helpful when it comes to interpreting these rhythms. The next thing you need to be able to do is actually measure the EKG itself. To interpret if it's normal or abnormal, there are going to be certain numbers you have to know. And if you can't measure these complexes, it's not going to be worth much. So you usually get an EKG in a 6-second strip. Every 1 second is represented up here on my screen right now. We break every 1 second down into 5 big boxes. And we break every big box into 5 little boxes. So going from biggest to smallest, we have 1 second. That's 5 big boxes. And then every big box has 5 little boxes. So if you do some simple division, that tells you how long each of the boxes are. 0.04 is each little box. We put 5 of those together, we get 1 big box. And the big box is 0.2 seconds. We put 5 of those together and we get a second. So 1 second, 5 big boxes. Each big box is 5 little boxes. 0.04 seconds for the little box, 0.2 seconds for the big box. 5 big boxes gives us 1 whole second. Now, if you've lost you and you're not quite sure how to count all of that, we're going to do some practicing, all right? For right now, I just want you to remember 0.04 little box, 0.2 big box, all right? There are 5 steps that you're going to take when you're interpreting each and every EKG. The first thing you're going to do is ask yourself if there's 1 P wave for every 1 QRS wave. Every 1 time the atria contracts, we need the ventricles to contract 1 time, 1 to 1. If there are more P waves than QRS complexes or vice versa, then we definitely have a problem. After you've looked at that, step 2 is the PR interval 0.12 to 0.2 seconds? And this is where that knowledge of your little and big boxes is going to come in handy. Let's look back at that strip again. When you're looking at the PR interval, what we're talking about is the time from the beginning of the P wave all the way to that big spike, that top of the QRS complex. It's the interval between the start of the P and the R. We want it to be 0.12 to 0.2 seconds. So the only way for me to measure that is to count the little boxes that show up. Looking at this, I see 1, 2, 3, 4, just over 4 little boxes. And I know my little boxes are 0.16 seconds. So that PR interval is 0.16. Is that normal? Yes. 0.12 to 0.2 is my normal PR interval. So I actually like to think of it just in terms of those little boxes. I want it to be 3 to 5 little boxes. If that's how long the start of my P wave to my big R is, it's a normal PR interval. All right, step 3, we need to measure that QRS complex. And the words I want you to remember are tall and narrow. Tall and narrow are the normal attributes of a QRS complex. If they are wide, that's a problem. So I just need that QRS to be less than 0.12. That is less than 3 little boxes. Again, let's practice and look back at that EKG. You see that big QRS spike? And look, it spans really just over one little box, 0.04 to 0.06 perhaps. It's certainly less than 3 of those little boxes. So we know this is a normal QRS complex. It is tall and narrow. All right, you've made sure there's 1 P for every 1 QRS. You've measured the PR interval, and you've measured the QRS complex. Fantastic. The next step 4 is determining the rate. Now, to determine the rate, all we need to do is a little bit of counting, okay? I told you that you're normally going to see an EKG in what we call a 6-second strip. That is, we're going to have 6 seconds represented in this EKG strip. That's really handy for us because when you multiply 6 by 10, you get 60. And how many seconds are in a minute? 60. That means when you're looking at these strips, if you count how many QRS complexes there are, and you multiply them by 10, you get the heart rate. So do a little practice here with me. We have 1, 2, 3, 4, 5, 6, 7 QRS complexes. 7 times 10 is 70. My heart rate for this client is 70. Now, of course, keep in mind that normal heart rates vary for different age groups. For adults, we want the heart rate to be 60 to 100. That's going to be our normal rate. And that's the 4th thing we look at in our EKG interpretation. Last but not least, we have to determine if the heart rhythm is regular. Now, what exactly do I mean by regular? I mean that all these QRS complexes are marching out to a steady beat. If this was a song, the rhythm would be regular. You would hear a steady, even beat. You wouldn't hear 1, 2, 3, 4, 5, 6, 7. You're going to hear 1, 2, 3, 4. So to evaluate that more objectively, look at these 2 rhythm strips and count the number of big boxes between your QRS complexes. On this rhythm up here at the top, we have 1, 2, 3, about 4 big boxes. Then between the next 2 sets, we have 1, 2, 3, about 4 big boxes, so on and so forth. You can see that these QRS complexes are regular. They're evenly spaced. Now, if you compare it to the rhythm down below here, this is not a regular rhythm. We have a QRS here that has 1, 2, 3, 4, 5, 6, 6.5, 7 big boxes between QRS complexes. And then here, 1, 2, just over 3 big boxes between that QRS complex. They are not spaced evenly. So that's an example of a rhythm that is irregular. So let's review. 5 steps to EKG interpretation. 1 P wave for every 1 QRS wave. We're going to make sure that we see 1 P wave and then 1 QRS wave. Not multiple P waves and then a QRS, or a bunch of QRSs without any Ps. Secondly, we're going to say, is the PR interval 0.12 to 0.2 seconds? Remember, that means 3 to 5 little boxes. If it's greater than 5 little boxes, which tip, that's one big box, we know that is too long. And you're going to see quite a few examples where prolonged PR intervals become an issue. So we want 3 to 5 little boxes. Now, step number 3, is that QRS less than 0.12? Remember, we want to make sure that that QRS is tall and narrow, less than those 3 little boxes. You see the example down here below where that QRS gets really wide, we have a problem. Fourth is the rate between 60 and 100. Remember, once again, for an adult. Count the number of QRS complexes you see in that 6-second strip and multiply it by 10. Here we see 7 heartbeats times 10. The heart rate is 70. And lastly, of course, make sure that you have a regular rhythm. We want to see that those heartbeats are coming at even spaces. Count the big boxes in between them if you need to be sure. If they're not spaced out evenly, we have an irregular rhythm. All right, so to recap, if you go through these 5 steps and you do see 1 P wave for every 1 QRS, that the PR interval is 0.12 to 0.2 seconds, that the QRS is less than 0.12 seconds, you have a rate between 60 and 100, and a regular rhythm, all 5 of those things put together tell me that my client is in normal sinus rhythm. And this is what we expect most of our clients will likely be in. Everything is functioning normally. Their atria are contracting and sending blood to their ventricles, and then their ventricles are contracting and sending blood out to the body. The electrical activity is flowing through that electrical highway exactly how it should. So remember, when you check all 5 of those things in order and all 5 are true, you have normal sinus rhythm. Let's talk now about what happens when this isn't what we see. If any of those 5 things that I told you to look for are not true, you have what we call a dysrhythmia. The electricity is not flowing through the heart exactly like it should. So let's talk first about the 2 sinus dysrhythmias. We call them sinus dysrhythmias because they are still having electrical activity move through the sinoatrial node of the heart and down that electrical highway like they're supposed to. They're just either doing it too fast, like in sinus tachycardia, or they're moving too slow, like in sinus bradycardia. So again, these dysrhythmias are forms of sinus rhythm. They have 1 P wave for every 1 QRS. Step 1, check. They have a normal PR interval, 0.12 to 0.2. Check. 3, they have normal QRS complexes. They're less than 0.12 seconds. Check. Also, step 5, the regularity checks out. Those QRS complexes are in fact coming at regular rates. They're spaced out evenly. In sinus bradycardia, it's just too slow. That rate is less than 60. So what can cause sinus bradycardia? Well, it can be something very innocuous. Sleep, inactivity, maybe somebody is really out of it. Maybe they're super athletic, or marathon runners notoriously have very low resting heart rates. Maybe they've taken a drug that has reduced their heart rate, like a beta blocker or digoxin. Or maybe it's not something so innocuous. Maybe it's something like a myocardial infarction, where their muscle of the heart has actually been damaged and the heart is slowing down. So very, very wide range of causes. And your intervention is to fix the cause. If my client is just sleeping really deeply and their heart rate is in the 40s, I probably don't need to give them any medication. I might need to wake them up a little bit. Or perhaps that's their normal heart rate, and that's okay. Now, if my client is symptomatic, they're having poor perfusion due to this sinus bradycardia, of course, I do want to do something. And the medication that we give for bradycardia is atropine. If we have symptomatic bradycardia and we need to increase that client's heart rate, atropine is the medication to remember. Now, on the flip side, what if we have sinus tachycardia? Remember, in this dysrhythmia, the electricity is still moving through that electrical highway in the correct order. We have one P wave for every one QRS. The atria and the ventricles, they're still communicating with each other. They're still coordinated. The PR interval and the QRS complex, they're normal. And it's a regular rhythm, even spacing between those QRS complexes. The only thing from your 5-item checklist that's abnormal is the rate. The rate for adults, it's going to be greater than 100. This is a fast heart rate. So what can cause sinus tachycardia? Well, there are even more causes here than there were with sinus bradycardia. Caffeine, exercise, a fever, anxiety, pain. These are all very common causes of sinus tachycardia. It could also be something a little bit more dangerous. Hypotension and volume depletion are something I want you to be very aware of as potential causes of sinus tachycardia. When the blood pressure goes down, the heart knows that it needs to do something to get the cardiac output back up. The only way it can compensate for decreased blood pressure, that volume depletion, is by increasing the heart rate. So compensatory tachycardia is the body's way at trying to maintain perfusion by increasing the cardiac output. When you think about what your interventions are for sinus tachycardia, there is no one end all be all that I can put up on this slide. You have to figure out what the cause is. If they have a fever, we're likely going to give acetaminophen. If they're in pain, perhaps they need pain medication. If they have a low blood pressure and volume depletion, we need to give them IV fluids. These are very, very common interventions, but they depend on the cause of the sinus tachycardia. All right, now that you understand the sinus dysrhythmias, it's time to talk about my personal favorite EKG topic, heart blocks. Heart blocks occur when there is some sort of disruption or block in the electrical activity moving down that electrical highway of the heart. Maybe between the sinoatrial node and the AV node, there's a block, or maybe it's lower. Maybe it's down between the AV nodes going down to the bundle branches. For whatever reason, there's some sort of disruption on that highway. You can kind of think of it like a traffic jam, and we can see that disruption on the EKG. There are 4 types of heart blocks you have to know for the NCLEX. First-degree heart block occurs when we have a lengthening PR interval. The time that it takes that electricity to get from the atria to the ventricles is too long. So, from the beginning of my P wave all the way to my big R spike is greater than 0.2 seconds. Remember, the normal PR interval is 0.12 to 0.2. In first-degree heart block, all of my other list items check out, but my PR interval is too long. It is greater than one big box, greater than that 0.2 seconds. What can cause first-degree heart block? Often this is just an incidental finding. In pediatric clients, sometimes it's an infection, inflammation that causes this. Myocarditis and inflammation of the myocardium, that muscle of the heart. Or again, in pediatrics, congenital heart disease can cause this blockage. Again, it's often incidental, which means that we do an EKG for other reasons and find, oh, they're in first-degree heart block. That means usually we're not seeing a lot of symptoms. This client still has appropriate cardiac output and they're feeling quite well. So we'll treat the cause if they have an infection, a myocarditis. If they have congenital heart disease, of course, there's usually a surgical intervention that needs to take place. But treatment specifically for that first-degree heart block is usually not required. We'll just need to take care of whatever was causing it. If it is extreme and it's causing a decline in cardiac output, my client is having symptoms, well, in that case, we would need a pacemaker. You're going to see a common thread here for our heart blocks. Pacing is often the intervention. So your next heart block is second degree, type 1. We have two types of second degree heart block. Type 1 is also known as Mobitz 1, or my personal favorite, Winky Bach. So what happens here, when you look at the 5 different items you have to review for all EKGs, again, everything is normal except that PR interval. But in type 1, or first degree heart block, we had a prolonged PR interval and it was the same, just too long. In second degree, type 1, we have a PR interval that starts out as normal, then it gets a little longer, then it gets a little longer, and then all of a sudden we have what's called a dropped beat, where there's a P wave and no QRS complex. That electricity doesn't get from the atria to the ventricles, and we miss the ventricles contracting. We miss a heartbeat. So the PR interval gets longer, 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 drop. And then you have a Winky Bach. That's how you can remember second degree heart block type 1. What causes this? What causes this? Well, again, it often is an incidental finding. People can be in second degree heart block type 1 and not even know it. It could be caused after they have surgery or have some sort of irritation or inflammation to the muscle of their heart, such as that myocarditis or maybe some sort of ischemia where the myocardium's not getting enough blood flow. Once again, your intervention is to treat the cause. If they're asymptomatic and they have sufficient cardiac output, then we really don't require treatment. But once again, if they are symptomatic and we do need to treat second degree heart block type 1, we will do so with a pacemaker. So second degree heart block type 2 is a little bit different. This is the only heart block where we do in fact have a normal PR interval. You saw in first degree, we had a prolonged PR interval. In second degree type 1, the PR interval got longer, 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 and then dropped. And in second degree heart block type 2, we have a regular PR interval. The item from our 5-item checklist here that doesn't check off is that we do not have one P wave for every one QRS wave. Intermittently, we have those dropped beats where we see a P wave and then no QRS complex. That electricity gets blocked going through that electrical highway and it doesn't make it from the atria to the ventricle. So the atria contract and the ventricles don't. That's why we don't see a QRS complex. It happens randomly. So we see here that there's a QRS and then we have a T wave followed by a P wave and we're waiting for another QRS. And then we have another P wave. It starts all over. We have a few beats that happen as normally, and then it happens again. We get that dropped beat where we see P wave, nothing, nothing, nothing. We're waiting for a QRS. We get another P wave. All right, so second degree heart block type 2 is a little bit bigger of a deal. There's a higher risk that this is going to progress to something more serious. And it's usually caused by damage to that myocardium. So perhaps there's ischemia going on where blood flow isn't getting to the muscle of the heart. We have a myocardial infarction, or perhaps there's some sort of inflammatory process like myocarditis causing irritation to that muscle. Now, whatever the cause, you need to try and identify and fix that. Pacing is going to be our go-to intervention in second-degree heart block type 2. Now, I mentioned it can progress to something a little bit more serious, and that would be third-degree heart block. Third-degree heart block is something I really need you to understand for the NCLEX because we consider this to be a potentially lethal arrhythmia. And you have to be able to identify that to get these questions correct on your exam. In third-degree heart block, we have complete dissociation between the atrias and the ventricles. Basically, the atria of the heart are doing their thing and the ventricles of the heart are doing their thing. They've gotten divorced, so to speak, and are no longer communicating. Remember that the P waves represent our atria contracting and that QRS complex represents the ventricles. So what are we going to see when they get disassociated? We're going to see that those P waves do their own thing, and the QRS complexes do their own thing. They're just not going to be related to each other anymore. So we see a regular P to P interval. Those P waves come at regular intervals. And we see a regular R to R interval. Those QRS complexes are coming at regular intervals, but they're not related to each other. All right, so we're not going to see a regular PR interval. There's going to be P waves, but there might not be one P wave for every one QRS wave. We might see two P waves and then a QRS. We might see a few QRSs before there's another P. It's going to be variable. This is an example of an irregular rhythm. And as I mentioned, third-degree heart block is a big problem. This client is not going to have sufficient cardiac output to perfuse their vital organs. So we consider this a potentially fatal rhythm. And for that reason, we do need prompt intervention. So we see some similar causes here to as we saw with our other heart blocks, damage to that muscle of the heart in some way, shape, or form. Whether it's ischemic damage, maybe leading to a myocardial infarction, damage to one of the valves, inflammatory damage, maybe they have something like rheumatic fever or sarcoidosis, where we're getting a lot of inflammation in that heart muscle. And the electricity is just not able to conduct down that electrical highway like it needs to. In third-degree heart block, your client will be symptomatic. There's no wait and see if they possibly need pacing. You are going to pace them. Pacing is the necessary intervention. Most clients that I've ever taken care of with third-degree heart block, they ended up with a permanent pacemaker because they can't live with their atria and their ventricles not talking to each other. It just doesn't work like that. They're not going to have sufficient cardiac output. So we need to send that electricity through their heart for them. And the way we do that is with a pacemaker. So I know this can be super hard to understand. I didn't learn a whole lot about heart blocks in nursing school myself. And when I was studying for my NCLEX, I came across this awesome, silly little poem that really helped me remember these. So let's go through our heart blocks together and put them to this song. If the R is far from P, then you have a first degree. Remember, in first degree, we had a prolonged PR interval. The R was far from P. So we had a first degree. Longer drop, and then you have a winky Bach. Remember, second degree heart block type 1 is also called Mobitz 1, and it's also called winky Bach. It has a lot of names. And in winky Bach, that PR interval gets longer, and then we see that dropped beat where we've got a P wave, but the QRS interval doesn't come through. So longer drop, and then we have a winky Bach. Now, if some P's don't go through, Then you have a Mobitz 2. For second-degree heart block type 2, also called Mobitz 2, remember we had that normal PR interval, but some of the P's didn't get through. What we mean by that is the electricity, it got to the atria, it made that P wave, but it didn't get through to the ventricles, and we had that dropped beat. We missed that QRS impulse. Some of that electricity that went to the atria, it didn't get through. It didn't get to the ventricles, and we didn't have a QRS complex. So with second degree type 2 or Mobitz 2, if some P's don't go through, then you have a Mobitz 2. And lastly, we saw with third degree, if P's and Q's disagree, then you have a third degree. The P's and the Q's, the atria and the ventricles, they got divorced. They're not talking to each other. They have split up. The P waves are going at the rate of their own rhythm, and the QRS complexes, they're going at their own rate. We see no correlation between the two anymore. So when P's and Q's disagree, then you have a third degree. So I know this might be a little bit silly, but I promise for me, it really, really helped to cement what the findings on the EKG were for all of these different heart blocks. And as I mentioned with these different heart blocks, the main intervention was pacing. So this seems like a good idea to tell you guys a little bit more about actual pacemakers. All right. So first and foremost, what's a pacemaker? This is an external device used to send electricity through your client's heart. So if they have a heart block and that electricity is not going down the highway like it should, we're going to send that electricity for them. That's where our pacemaker comes in. We've got 3 types: transcutaneous, transvenous, and permanent. Transcutaneous means through the skin. So these are those pads that you see we might put on the client if we're going in an emergency situation. We're going to send electricity through their skin with those pads to stimulate electrical activity in the heart. So that's going to be a very temporary pacemaker situation that we can quickly throw on the client in an emergency and pace them. A little bit more permanent is transvenous, through the veins. This is when a client, they usually come back up from the operating room with transvenous pacing wires if they're at high risk after a cardiac surgery for going into a dysrhythmia. The cardiac surgeon will place wires directly on their heart. They'll be coming out through their skin and hooked up to a little box that can send that electricity straight to their heart. So they're not meant to go home with these, but they can stay in for a few weeks if they're at really high risk for dysrhythmias. And if they go into one of these rhythms, no problem, we can put some electricity straight to their heart and do that job of the electrical impulses for the client. Now, with our clients who are going to need a long-term solution, this is not an emergency or, an ICU post-operative intervention. This is their life. They're living in third-degree heart block, and they need a more long-term fix. They get a permanent pacemaker, something actually implanted in their body that's going to be able to send that electrical activity through the heart like it's supposed to. And this is really where I need you to focus in, because there's some client education surrounding permanent pacemakers I bet the NCLEX is going to ask you about. First thing is we want them keeping a little identification card in their wallet. If something happens to them, people are going to be able to find, this person has a pacemaker, and that's going to be important for the emergency medical services. Now, people ask questions about water. Can they take a bath? Can they take a shower? Can they go swimming? Yes. It's totally okay to get water outside their body, all right? That pacemaker is implanted inside. Bath, shower, that is allowed. What we don't want is pressure over that pacemaker. So really tight clothing, we don't want them doing that. We also want them talking on their phone on the opposite side of their body. so that we don't get any mismatching signals. We keep that generator safe. We also get lots of questions about household appliances. Can I use the microwave, the stovetop, the oven? Can I go through airport security? Well, all of those household appliances are totally fine. All right, the microwave's not going to interfere with it. The oven, the stove, they can cook like normal. It's not an excuse for somebody to not cook dinner, okay? They are fine to go to the airport, but we want them to let airport security know, okay? They might just do that hand wand instead of sending them through the big machine, okay? Big contraindication, an MRI. MRIs use magnets, all right? And there is metal in some of our pacemakers, all right? We've got tons of different types nowadays. There's very advanced and fancy-dancy pacemakers that are MRI compatible, but we want to make sure that they notify their healthcare provider and make sure they're aware of that before ordering any imaging, okay? Most clients with a pacemaker, we're not going to be able to send them into an MRI. So we might need to do something like a CT scan instead that doesn't use those magnets. All right, now that we've got our heart blocks out of the way, let's move on to talking about some atrial dysrhythmias. This means that something is going on up in the atria, right? So you should expect that there are going to be problems with the P waves, since the P waves are what show us that the atria are contracting. If we have atrial dysrhythmias, we may not have normal P waves. The first atrial dysrhythmia you could see is something called atrial flutter. And as you go through your checklist of the different things that you need to look at here, you're going to notice first and foremost that there is not a P wave for every QRS wave. All right, we have what appears to be a bunch of P waves, and they're in this funky pattern, this sawtooth pattern. If you see the word sawtooth or you see this characteristic pattern on an EKG, you know you're dealing with atrial flutter. We can't very well measure the PR interval because there are so many of these sawtooth waves. What we do see is that the QRS is normal. So the ventricles are still working here. And that's great. That means we're still going to have some cardiac output since the ventricles are contracting and sending that blood forward to my organs. All right, as I continue going through my checklist, now I'm going to check out the heart rate. And this is super hard to evaluate because before I had a P wave, a QRS, and I could easily just count those QRS complexes to see how many times the heart was beating. Well, not so easy anymore since my atria are going haywire. My atrial rate, if I count all those sawtooth patterns, it's going to be crazy high, like 250 to 400, totally unsustainable and really not realistic. If I just count my ventricular rate, it's going to be much more normal. It will vary. Next, when I look up at my regularity, you'll see that atrial flutter can actually be either regular or irregular. In our example up on the screen now, you see a regular atrial flutter. There are 3 sawtooth patterns and then a QRS. 3 and then a QRS. They come at regular intervals. This can deteriorate further, though, to where they're coming sporadically, irregularly, and we have an irregular atrial flutter. So what can cause this? Heart disease, a myocardial infarction, our clients in congestive heart failure, or those who have any sort of inflammation to their heart, pericarditis or myocarditis. That can inflammate the atria and cause them to go into this dysrhythmia, this atrial flutter. So like we've seen with all of our other rhythms, your first intervention is to fix that cause. What has made the heart get so irritated that the atria are fluttering and creating this sawtooth pattern? Now, a lot of these clients are not going to have good cardiac output. So while we're trying to fix the cause here, what other interventions do we have up our sleeve to help? The first one is cardioversion. All right, we're going to get into the nitty-gritty about cardioversion versus defibrillation here in a minute. But to start us off, let's talk about what is cardioversion. We talked about pacing and how you have to send electricity out for the body. So when that heart is maybe in a heart block or bradycardia and it's not sending appropriate electrical activities, we do it for the heart. Well, cardioversion is an attempt to reset the heart to get it out of that dysrhythmia and start that electricity going back through the normal pathway. We use cardioversion when the client has a pulse. We want to synchronize us sending electricity through the heart with what the client already has going on. And if they have a pulse, we know that the ventricles are sending some blood out to the body. We can literally feel it. That's what the pulse is. The pulse is the ventricles contracting and shooting that blood forward. We're literally feeling that pressure radiating through our client's body in their pulses. So if that's already going on, the ventricles are contracting and sending that blood forward, and we've got our atria doing this crazy flutter, we might need to try and reset that heart to get the electricity moving through those atria correctly. And cardioversion is one of the ways we can do that. A big jolt of electricity synchronized to be in time with that client's current electrical activity to hopefully reset that heart and get it out of atrial flutter. Now, those are pretty extreme measures. We're likely only going to do that for a client who really is not tolerating this rhythm whatsoever. We may have clients who, they need a little bit of help, but we can try some other interventions first. So some pharmacologic interventions that we might give a go. We might try amiodarone. That's one of our antiarrhythmic medications that may help get this client out of a flutter. We may try the beta blocker metoprolol to slow that heart rate down. And we may try that calcium channel blocker diltiazem to help regulate that heart rhythm as well. So we've got antiarrhythmics, beta blockers, calcium channel blockers as our pharmacologic treatments for atrial flutter. And then a step up from that, we might use cardioversion and pacing. Next, we have atrial fibrillation. And I bet you've heard of this one before. It's one of our more common dysrhythmias. It occurs when our atria deteriorate from the point of producing normal P waves, the point of even producing that sawtooth characteristic pattern, to now just fibrillating. Fibrillating means like a quivering, a shaking. They're really not contracting and sending blood forward to the ventricles. So instead of a P wave or even a sawtooth pattern, we just get this wavy line. There really are no P waves and therefore really no PR interval for us to measure. When we look at our QRS complex though, it's still normal. We still have a narrow QRS complex less than 0.12 seconds. That's great. That means our ventricles are still doing what they're supposed to do, contracting and sending blood forward. The atrial rate, when we try to determine the rate and regularity for this rhythm, that's going to be something crazy. It's going to be really hard to determine looking at this big wavy line. The ventricular rate will vary, all right? As we see here on this screen, we have a pretty normal ventricular rate, about 90, if we count those QRS complexes and multiply it by 10. But it is irregular. We see they're bunched up, and then there's a little space, and then they have a few more, and then a little bit of a pause. They're not coming at regular intervals anymore. So this client has poorer cardiac output. They're not getting as good of perfusion. And it can lead to a lot of long-term complications because, believe it or not, we do have clients who live in atrial fibrillation and are stable and spend years and years of their life in this dysrhythmia. It can be caused by quite a few different things: heart disease, pulmonary disease. Anytime we have really severe pulmonary disease, it increases the pressure that our right ventricle has to pump against. And that right ventricle over time can wear out and we can start to see some dysrhythmias. This can even happen with prolonged exposures to stress, alcohol, or caffeine, or a combination of those three things. And when a client goes into atrial fibrillation, often they're going to feel weak, sweaty, they may look pale, and they may feel palpitations. They could be completely stable and able to live at home with this disorder, or they could need intervention. So, what shall we do if our client needs intervention for atrial fibrillation? Of course, fix the cause. If they've got some sort of myocarditis, rheumatic fever, we're going to treat that. If they have an ischemic process, we want to restore blood flow to the heart. And once we've done so, we've treated the cause. Hopefully that dysrhythmia will resolve. Now, interventions we can take to specifically address atrial fibrillation are cardioversion, like we just talked about with A-flutter, antiarrhythmics such as amiodarone, beta blockers such as metoprolol to slow that heart rate, and then we have one additional. We can do something called an ablation. This is a surgical procedure where the surgeon goes into the heart and finds the area causing the dysrhythmia. Sometimes there's a bundle along that electrical conduction highway of the heart that's sending out these haywire electrical impulses. It's a rogue driver on the freeway on this electrical highway, and it's causing all of these erratic electrical activity or impulses to go out. And if the surgeon goes in and removes that tissue or ablates it, he gets rid of that crazy driver, traffic can resume as normal, and we can get rid of the stimulus that's causing this dysrhythmia. So an ablation is something that you may see done for a client in chronic atrial fibrillation to get that resolved. Now, it's not up on the slide, but one additional key piece of information that you need to know about atrial fibrillation is that if your client does in fact go home living in chronic atrial fibrillation, they must be anticoagulated. Usually this is going to go with warfarin. We're going to monitor their INR to make sure they stay at a therapeutic INR. Why? Well, if the atria are not contracting, they're just quivering, they're fibrillating, they're not sending blood forward. And blood that's not moving forward, blood that's just sitting in the atria, it clots. Blood that's sitting still clots. And I really don't want clots to form in the atria of my heart. Because if they then get dislodged and moved forward, oh my gosh, if it was in my right atria, it got dislodged, it would move forward into my lungs. I could have a pulmonary embolism. If it was in my left atria and it got dislodged and moved forward to the body, it could go up to the brain and cause a CVA. It could go out anywhere in the body, really. It could get back in the coronary arteries and cause a massive MI. There are a lot of severe life-threatening complications that can come from this clot dislodging and going out into the body. So to mitigate the risk of these clots forming, if my client goes home in chronic atrial fibrillation, I have to make sure they are on an anticoagulant. All right, our next and last atrial rhythm is something called supraventricular tachycardia. Now, I know it's got the name ventricle in there, so you're probably saying, hang on, Morgan, this is a ventricular dysrhythmia. It's not. Supra means above. So this dysrhythmia occurs just above the ventricles. All right, this is one of the more common things that we can see post-operatively. And what happens is we get a really, really fast ventricular rate. It's so fast, in fact, that it hides our P waves. My atria are still contracting here. I am having P waves, but my ventricles are contracting so fast that they're covering them up. So when I'm looking at a rhythm and I'm trying to decide if it's SVT or sinus tachycardia, I go to step 1 of that 5-step process for EKG interpretation, and I look for those P waves. If I can see P waves, it's sinus tach. If I cannot see P waves, it's SVT. So in SVT, we see hidden P waves, and then of course step 2, measuring your PR interval, that's impossible since we can't see our P waves. Step 3, your QRS complex, well, it's still normal. Tall, narrow, less than 0.12 seconds. Great. The rate, however, is a problem. It's going to be very, very fast. For adults, it has to be greater than 150, and I'll be honest with you, most of the times, it's at least greater than 180. In children, it has to be greater than 220. We also see not only is that rate really fast, but it is super regular. Not just like, oh, it's regular, it's coming at normal intervals. It is so regular that it's not normal. You know, if I'm watching the EKG monitor for one of my clients, their heart rate, even normally regular, is going to have a smidge of fluctuation, right? It's going to be 60, 62, 64. It's going to slightly vary. With SVT, they get locked in. So when I look up at the monitor and my patient has gone into SVT, it says 180 and it stays right there at 180. That's another thing that clues me in as the bedside nurse. Oh, this client is in SVT. Super regular, super fast, and I can't see any P waves. So what can cause this SVT? Again, stress to the heart like caffeine, stress, alcohol, congestive heart failure, putting all that pressure on the heart, incredibly fatigued or hypoxic, and they might be fatigued because they're hypoxic and we're not getting that oxygen to the heart, or some sort of alteration to that SA node, that pacemaker of the heart. What do we do when our client is in SVT? First things first, I want you to assess them. Follow your nursing process and ask yourself, are they tolerating this rhythm? Do they have sufficient cardiac output? What's their level of consciousness? Do they have good pulses, perfusion? Are they nice and warm and pink and they're sitting up talking to me? All right, I would say they're tolerating that rhythm. Are they cool, pale, clammy, mottled, delayed cap refill? They're not mentating appropriately. That tells me their brain's not getting enough oxygen. All right, they're not tolerating this rhythm. This SVT has caused them to not have enough blood flow out to their vital organs. So let's talk about our interventions from least invasive to most invasive. My least invasive intervention for SVT is a vagal maneuver. Getting my client to bear down, stimulate that vagal nerve, that's cranial nerve 10, can sometimes flip them out of this rhythm and they'll get back into normal sinus rhythm. So for adults, you can just tell them bear down, like you're going to the bathroom, like you're having a bowel movement. For kids, we've got a few tricks. For infants, you can put ice to their face. That makes them and bear down. Older kids, you can have them blow on a pinwheel or something like that, or blow bubbles. That'll cause them to bear down. I'm not going to lie to you. A lot of times, vagal maneuvers don't work. So we might need to step it up a notch and go to our pharmacologic interventions. Pharmacologic intervention for SVT is adenosine. All right, SVT adenosine. Adenosine is like pharmacologic cardioversion. Remember I told you cardioversion reboots the heart? Adenosine does that. It's just a medication instead of that electricity. So we administer it to our client. They're going to flatline on the monitor, and hopefully they're going to come back in normal sinus rhythm. Obviously, there's some nursing considerations you need to know about this medication since it's going to make them flatline on the monitor. First things first, for it to work, you have to give it quick. Rapid push as close to the heart as possible. For that reason, we prefer a central line over a PIV, and we prefer for that IV access, wherever it is, to be closer to their heart. So if I have an NCLEX question that tells me I have a peripheral IV in the hand and one in the antecubital space, the AC, which one should I give my adenosine in? I'm going to pick the AC, closer to the heart. From the time I push that adenosine, I have about 2 seconds to get it from my syringe all the way to the myocardium, or it doesn't work. Rapid push, close to the heart, prefer a central line. I also need, if I'm a nice nurse, to give my patient and their family some heads up about what's about to happen. If your client's awake, they're going to feel like they got kicked in the chest. Their heart is stopping. Let them know, like, I'm so sorry. This is going to hurt. This is what this is going to feel like. We expect this so that they don't freak out. Same thing with the family, okay? Let them know what they're going to see on the monitor. They have all watched Grey's Anatomy. They know when they look at a little flat line on the monitor and everything's beeping like crazy that it's not good news. So they might freak out a little bit if you don't let them know, hey, this is what we're doing. This is why we're doing it. This is what we expect to happen, okay? They're going to come right back. Now, last nursing consideration, and I'm happy to say that this has never personally happened to me, but there are reported incidences where our adenosine has worked a little too good. Our client has gone into asystole, they flatlined on the monitor, and not come back into normal sinus rhythm. Okay, so in that instance, we want to make sure we have some epinephrine drawn up at the bedside. If this turns into a code situation, we just want to be ready for it. So have some epinephrine at the bedside just in case, just a little backup dose, all right? Like I said, it's never happened to me, but there are reports of that happening. So a good NCLEX safety check, if you're giving adenosine, have some epinephrine at the bedside. Key things I want you to take away from that whole spiel: rapid push, close to the heart, and make sure to warn the client and their family about what's happening when you give that medication. Last thing I'll say here is that a lot of students tell me they have trouble remembering which medications to give for which dysrhythmia. So I want to reinforce that adenosine is SVT and atropine is for bradycardia. All right, Archer nurses, we have one last group of dysrhythmias to talk about, and these are the most serious. Your ventricular dysrhythmias are where the electrical activity has deteriorated so far that the atria aren't working at all, and now we have problems in the ventricles as well. So first, we're going to talk about ventricular tachycardia. Now, the key word you need to remember here is wide and bizarre. If you're looking at an EKG strip and you see no P waves, therefore no PR interval, and you go to measure that QRS complex and it is way greater than 0.12, way greater than just those three little boxes. It is wide and bizarre. This is ventricular tachycardia. We have a high rate. We do see that it's regular. What's happening here is that the ventricles are just contracting, trying to get some cardiac output out to the body, but it's in this really wide and bizarre pattern. It's kind of a futile attempt to perfuse this client. Now, clients can have a pulse with VTAC. We have VTAC with a pulse and VTAC without a pulse. And you need to assess for that pulse so that you can determine your appropriate intervention. Things that can cause ventricular tachycardia are anything that damages that muscle of the heart. Myocardial ischemia, infarction, digoxin toxicity, toxicity with any drugs, hypoxia, acidosis, an imbalance in the client's potassium level, high or low potassium, hypotension. If we have a really low blood pressure, we're not going to be getting oxygen and blood flow to that muscle of the heart. That's going to cause ventricular arrhythmia. We could see ventricular tachycardia. As I mentioned, this client can have a pulse. They don't always have a pulse. And that's the first thing I need you to do. Check for that pulse for 5 to 10 seconds. You never want to delay intervention greater than 10 seconds. If you can't feel a pulse in 10 seconds, you're going to proceed to that ventricular tachycardia without a pulse. If you do feel a pulse, however, though, we are going to cardiovert this client. No pulse, and we are going to start CPR. We can administer epinephrine, and we will defibrillate this client. All right, now, if none of those interventions are effective, it's very possible that your client will deteriorate into ventricular fibrillation. Now, back in VTAC, we didn't have any P waves, but we still had a QRS complex. Even though it was wide and bizarre, the ventricles were doing something. In VFib, we have none of that. No P waves, no atria, no QRS complexes. The ventricles are no longer contracting in any sort of organized rhythm. Instead, they are just quivering, shaking, fibrillating. They are not producing sufficient cardiac output to send blood forward to your client's tissues. So in VFib, we do not have a pulse, and this is an acute, life-threatening arrhythmia. Your priority intervention in ventricular fibrillation is defibrillation. You can remember this: VFib, defib, all right? Whenever you see VFib, you want to immediately shock that patient as soon as you possibly can. Here's our thought process behind this. What we're seeing is a wavy course line of chaotic electrical activity that's not getting the heart to beat. There's electricity in there. We see that from that wavy line, all right? But it's not organized enough to actually cause those ventricles to contract and send blood forward. That's what we need to perfuse the body. When we defibrillate the client, we are sending electricity into that heart to try and organize the electrical activity and get those ventricles working together and sending blood forward. So VFib, defib. You're going to see a lot of similar causes to what we already talked about in VTAC. Anything that damages the muscle of the heart. If it's not getting blood flow, we have some sort of ischemia, maybe leading to an infarction. If we have some sort of toxin, maybe that is hydrogen ion acidosis. We have too many hydrogen ions that causes our blood pH to be too low. Maybe we have toxicity with a drug like digoxin. Maybe we have high or low potassium levels. No matter what the reason, VFib, if you see it, most common cause of sudden cardiac death. So we want to take this very seriously. Number one priority is to defibrillate. You can then resume CPR, compress the chest, and administer epinephrine. Those are going to be your big three interventions. So let's get into the nitty-gritty on those differences between cardioversion and defibrillation. We've talked about both of them at this point. You should have picked up on the fact that we cardiovert clients who have a pulse. So when we talked about SVT or when we talked about ventricular tachycardia with a pulse, if your client has a pulse, we cardiovert. Another name we might hear is synchronized cardioversion. So what this means is that we're synchronizing the shock with the client's own rhythm. And that's going to help to make sure we deliver the shock at the right time. If our client doesn't have a pulse, that's when we defibrillate. So the two times we defibrillate are VTAC without a pulse and VFib, defib, all right? Defibrillation happens at a bit of a higher energy. For adults, we see about 200 to 360 joules. In pediatrics, it's 2 joules per kilo. And then in cardioversion, we see a little bit lower. For adults, it's that 100 to 360 joules. If you don't see a response with your first shock, you might turn it up for the second shock. The point of both of these interventions is to organize the electrical activity in the heart so that when we shock the client, it puts them back into an organized rhythm. Hopefully, if all things go well, back into normal sinus rhythm. Unfortunately, that's not always what happens. We can see this progress all the way to our last rhythm, asystole. In asystole, we don't have any waves. There's no P waves, no QRS waves, none that are wide and bizarre, not even that coarse wavy line. That coarse wavy line from ventricular fibrillation, that told me that, hey, there was some electrical activity in the heart. It wasn't organized. It wasn't causing the ventricles to contract and send blood forward, but there was some electricity. That's what allowed me to defibrillate that client and try to get that energy organized so that we could have some cardiac output. In asystole, there is nothing. And that means we cannot defibrillate a client who is in asystole. There's no electrical activity to reorganize. My only two interventions for asystole are CPR and epinephrine. I'm going to want to provide continuous high-quality CPR and administer epinephrine 1 milligram every 3 to 5 minutes. There's no maximum for how much epinephrine you can give. As long as this code is going on, you want to give epinephrine every 3 to 5 minutes. And it's really critical at this point to try and identify why the client has had a cardiac arrest. What has sent them in to asystole? Are they acidotic? Do they have a potassium of 8? Or perhaps did they overdose on a medication? Do they have a really high digoxin level? You need to check your boxes for what are the most common causes of these cardiac arrests and fix any of them if they're present. So for example, let's say we get an arterial blood gas and we find that that client's pH is 6. All right, that's not really compatible with life. So we need to do something to fix that acidosis. That's just for example, whatever the cause is identified of, we need as a team to get working very quickly to reverse those causes, or we may not get this patient back from this code. All right, let's wrap up this lecture with a little bit of a practice scenario. I want you to remember all of those different rhythms, how to interpret them, and the different interventions you have learned. So you are an ED nurse right now. You're working when EMS calls in that a 42-year-old woman fainted at home and she's on her way in. She's unresponsive to voice, but does open her eyes to pain. And she's breathing and has a really rapid pulse. So what do you do first? I want you to pause the video, jot some notes down about what you think the next actions should be. I want to assess the client a little bit further. So what are her vitals? How does she look? Is she maintaining her airway? Go through your ABCs. Does she have an open, patent airway? Is she breathing? And what does her circulation look like? Is she pale, cool, clammy, mottled? Is she nice and warm and pink? So we get some vitals on this client. Her heart rate is 190 and regular. She's not breathing very well. EMS told me that she is breathing, but not very much, just 4 times a minute. And she's profoundly hypotensive at 62/38. She's also desaturated. Her oxygen is 72% on room air. So I know something's going on that's causing this client not to have good blood flow to her tissues. We've got a breathing issue. We've got a circulation issue. I need to prioritize this client right away. And seeing that her heart rate is 190 and regular, there's a certain action that I need to take right away to figure out what's going on. All right, so pause again. What are you going to do next with this information? Did you say get a 12-lead EKG? I hope so. We need to figure out what type of tachycardia this client is experiencing. Is it sinus tachycardia, supraventricular tachycardia, ventricular tachycardia? We have different interventions depending on what's going on. Because this client's heart rate was greater than 180 and it was regular, I'm worried about SVT. So we get that 12-lead EKG, we look at it, and what do you notice here? No P waves, right? We don't see any P waves, and we have an extremely regular, narrow QRS complex tachycardia. I'm worried that this is SVT. So what are my actions? Again, pause here, jot down your 3 actions for SVT from least invasive to most invasive. All right, first, vagal maneuvers. If your client is stable, have them bear down. Is this client stable? No, they're profoundly hypotensive and desaturated. So I'm not going to try vagal maneuvers. I'll go right to step 2. adenosine. Remember, that's pharmacologic cardioversion. Pause your video again and write down, how do you give adenosine? Rapid push with a good flush of normal saline, and we want to give it as close to the heart as possible. You only have a couple of seconds to get that medication from the syringe all the way to your client's heart. So rapid push of that adenosine. That doesn't work. Step 3 is synchronized cardioversion. This client has a pulse, so we need to cardiovert. And that's what we're going to do to this client. Let's say we tried our adenosine, it didn't work, so we decided to cardiovert. Let's check our EKG again. After cardioversion, this is what we see. Right. What's the first thing you need to check when this pops up on the monitor? Her pulse, right? We notice we have a wide complex for that QRS. It is wide and bizarre. I don't see any P waves. I can't measure my PR interval. This just looks like a wide and bizarre QRS complex. So I'm worried about ventricular tachycardia. And what I need to know is if it's VTach with a pulse or VTach without a pulse. That tells me what my intervention is going to be. How long do I check for my pulse? 5 to 10 seconds. Greater than 5, no more than 10. I don't want to waste time if the client doesn't have a pulse. So I'm going to go ahead and check 5 to 10 seconds. And even though the monitor is showing me a heart rate, this client doesn't have a pulse. That means that my ventricles are contracting wildly. We've got crazy ventricular tachycardia going on, but it's not producing sufficient cardiac output to actually send blood forward and give this client a pulse. They're not breathing. They're even more hypotensive and desaturated. So VTach without a pulse, what are my 3 actions? Pause again and jot it down. Priority, CPR. Get on the chest. We want to give compressions, push fast and hard. Step 2, as soon as we get that defibrillator ready, this is a shockable rhythm. The 2 things that we defibrillate are VTach without a pulse and VFib. Remember VFib, defib. No pulse, and we don't need to do the synchronized cardioversion. There's nothing we're syncing that rhythm to. So VTach without a pulse and VFib, we defib. Step 3, give our epinephrine. This is your code drug. You're going to give 1 milligram every 3 to 5 minutes. Remember, there's no max dose here. You can give as much epinephrine for as long as the code goes on, every 3 to 5 minutes. All right, so let's say you've done CPR for 2 minutes now. We pause for a rhythm check to see what's going on. And we see normal sinus rhythm. You go and check this client's pulse, and indeed, they have a pulse. This is what we refer to as return of spontaneous circulation. You'll hear a lot of nurses call this ROSC. We've gotten this client back, we've sent electricity through their heart and gotten that electrical activity reorganized, and now their heart is beating and actually sending blood out to the body. Great job, everybody. You've been through a lot of different rhythms today, and you were able to apply it to this scenario to actually go through what it's like to interpret these rhythms in real time and intervene for the benefit of your client. So if after watching this lecture, you still need a little bit more help, I do have some resources for you. My first recommendation is watch this video a couple times. All right, we went over a lot of information. You may need to go through it more than once. If you want a guided session with a little bit more one-on-one attention than just an on-demand video, our tutor Kate has small group workshops focused in on cardiac and EKG review. You can do some of those scenarios like I just showed you in real live time with her feedback. So if you're getting a lot of cardiac questions wrong and this is a low scoring area for you, scan this QR code or head over to your archerreview.com/private tutors. head over to Kate's tutoring page and see what she has to offer. It's a really good opportunity to actually ask questions and get those answers in real time. Okay, Archer nurses, that's all I have for you for today on EKG interpretation. Thank you so much for joining me. Thanks for walking through all of those rhythms. I hope you have a better understanding now of EKG interpretation. I'll see you back here next time.